Robin, thank you very much. Thank you very much for inviting me. And it's always we do some interesting stuff. I'll come on to some of that. And so I actually find it a pleasure to come out and talk about it, but also to hopefully stimulate some questions and some discussion. So thank you. And I can talk for 45 minutes. I could probably talk for more. We don't have to wait until the end. If there's something that kind of you stumble over halfway through, by all means, let's pick it up there and then if we wish. The question here is about the involvement of children in clinical research, and the thing that the basic question that we were looking at when we approached this was what seems to be something of a conundrum, which is on the one hand, medical research seemingly involves risk from which we should protect people, especially those who are seemingly vulnerable or not able to give their own consent to it. So we, on the one hand, want to protect people from that risk, and on the other hand, research is the means by which we get to better treatments, improved healthcare. So it's really how to break through that conundrum of protection and to some extent promotion of research. And in fact, children are actually quite poorly served by research and by healthcare, because medical research is often driven by the potential for whether it's profit or numbers, and children's healthcare is actually a relatively small part of the overall healthcare burden. So research is often not serving children well, and many treatments that children receive, especially medicines, have never been researched in children. Very often they are simply, we simply say, well, what's an adult dose? 100 milligrams. Let's divide it by 3 because by and large a child is a third of the weight of an adult. And actually that doesn't work very well. Children's metabolisms are different, it doesn't always work that way. But the research has often not been done. So children are in many cases receiving suboptimal medical care. So that's kind of part of much of the background. What I should just tell you a little bit about who we are. I've shuffled this around a little bit. I think I must have got a slightly updated my talk. So the Nuffield Council on Bioethics, we're an independent, some say think tank, that's not always the best word, but let's say an independent advisory body looking at ethical questions arising from developments in biological and medical research. We are funded by the Wellcome Trust, Medical Research Council and the Nuffield Foundation, but they pretty well leave us alone. So we operate independently in terms of what we look at and what we say about it. So we try and identify questions arising from developments in biological and medical research to promote public discussion and understanding about those questions, and to advise and inform policy. We publish reports, we publish other materials. Just to give some examples, one report published some years ago, which has been quite influential in many ways, is around public health. So this would be about, for example, the justification for public interventions, for large-scale public health interventions that might restrict people's choices but are for public health objectives. So typically it might be about fluoridation of water, or it might be around sugar tax. So these are effectively health interventions but operating on a public health level, and how this is justified from an ethical perspective, but it also then goes into a kind of political philosophy as well. So we don't draw very clean lines between some things. We're currently very much, I've been doing some work today which is around the bill which is before Parliament about moving to an opt-out system for organ donation, and the considerations around what are the benefits or the ethical considerations about shifting from an opting-in donation to one where there's a presumption of donation. So we published a report on that some years ago, and again we're engaged in public discussions. And most recently, genome editing for human reproduction. Our report earlier this year we've brought into active state with the reports just a fortnight ago of a Chinese scientist who had actually was reporting, he hasn't published it yet, having produced 2 babies whose genomes were edited during that early embryo stage to give them resistance to HIV infection. So we're kind of involved in some important public discussions. What we normally do, this is the way we normally work, is we have a council that kind of guides our programme. We will then bring together a number of experts from different disciplines, normally from medicine and science, but also philosophy, law, social sciences, but also public policy, and maybe some patient, other non-academic areas as well. We call in through a call for evidence or interviews, other people who can contribute to those things through meetings, through workshops, through discussions, through open calls, and then we will run that through council, through peer review, and publish other books. So that's broadly a kind of quite engaged process. So what we're not claiming to do is to simply have a handful of experts who simply know what's what and can simply give us answers. Actually, we kind of recognise that ethical expertise is something that is shared and needs to bring many different perspectives to bear. So we try to promote public debate and inform policy. And so in this case, along those lines, we did bring together a working party with a whole range of expertise across relevant areas in medicine, in social sciences and others. We gathered a lot of contributions through our consultation processes. We worked with people who were not only interested in the UK, but people working across other continents too. I'll come on to some of that in a moment, but clearly a lot of important research involving children does take place in low and middle income countries, where some of the most important health pressures and health burdens are felt, and we wanted to make sure we included those. So our aim, as I said at the outset, was to think about this question about how our immediate response is to think about how we protect children, given the sort of one of the intrinsic aspects of research is that there is likely to be some risk, there is no guaranteed benefit from it, but at the same time we want children to have access to evidence-based healthcare. And simply looking at that, we're, if you like, just thinking about what we do as experts or as researchers, and what quickly became obvious to us that the perspectives of children were not often represented in that whole conversation. And that was probably the one biggest thing that became clear to us at the early stages. So children, young people and their parents, how we might bring them into this whole consideration, both in what we're doing and in how research is thought about and conducted. So we refer to our participatory methodology. We got together a stakeholder group. It involved a number of children. We had about 50 people, children, young people, parents, people from patient organisations. We conducted a significant online survey involving young people in constructing that survey as well as listening to it. And we had 2 particular projects that we incorporated into this, which I'll mention them specifically. One was what we call the Youth Rec project. That's Research Ethics Committee project. And we effectively constructed a couple of research ethics committees with children from the kind of top end of infant school through high schools as well. And we worked with some medical researchers to construct a research project. This was about asthma, as it turned out, and pitched it to them as if they were a research ethics committee, and then invited them to go through all the kind of considerations that they thought would be important when thinking about what would be a reasonable way to go about this research, to recruit people into it, and then to manage the results. We then we've got some film of this, which I'll mention later, so it's quite interesting to watch. And we also ran that through an existing regular research ethics committee and let them reflect on it and see how actually what we were getting from the children was pretty wise and correlated quite well with what the adult research ethics committee was thinking of. The other quite significant piece of work was working with focus groups in Kilifi in Kenya. Now, Kilifi in Kilifi there is a major research centre that is supported by the Medical Research Council and the Wellcome Trust, and some of the people who were on our working group had connections there, and we had people coming back and forth. And so it was actually a really, really important and really illuminating part of the work, which was to kind of structure some workshops, some groups, some discussions with those people, the young people themselves, about the main questions about the acceptability of involving children, how decisions are made, and of course these cross-cultural questions as well, about how decisions get made within communities, within families, where sometimes decision making isn't quite as clear cut. I was in Singapore talking about this, and just observed that in the UK we've got this legal age of adulthood of 18, but of course that isn't necessarily the age at which we allow people to make decisions. We've got fairly well established principles that young people can make their own decisions if they have sufficient capacity and are able to understand and process that information. In Singapore, the legal age of majority is 21. However, typically, young people up to 25 live with their parents and defer to their parents, just as a cultural element, which is that they would expect their parents still to be making decisions on their behalf, actually into their 20s. Now, that doesn't mean to say that we need to take a completely different approach here, because those age limits are not actually what we ended up focusing on. But anyway, it's quite interesting, this kind of cross-cultural approach to it as well. And then a very important one was this question about the issue of conflating healthcare and research. Now, of course, for many, many people, when involved in medical research, there is some expectation of benefit. We kind of like to think that what we're going to get is going to be the best medicines available. In principle, research should be, there should be an equilibrium, that there is no assurance that the research arm will be more likely to give benefit than the control arm, whether it's a placebo or an existing therapy. And so in kind of medical ethics and law, we work with this idea of the therapeutic misconception, which that we have to disabuse people of this misconception that what they're going to get is necessarily a therapeutic benefit. So that's always interesting within any research context, but in low and middle income countries, this sometimes becomes much more difficult and complex, because often the researchers are going into communities that don't have much access to basic healthcare. And so the research that is being conducted is accompanied by some baseline healthcare that wouldn't otherwise be available. Now, you could consider that as an inducement, or you could consider it as a reasonable part of the package. And indeed, there are also cases where payment is given. That's not just in low and middle income countries, it happens here and elsewhere as well. So there's consideration of what would constitute an undue inducement to participate in research. And the questions in places like Kilifi are particularly interesting. We don't have a specific answer to that question, by the way, because that becomes a measure of judgment that is part of the process of consideration, and I can come on to that a bit later. So, thinking through or listening to all of those things, and in particular listening to the contributions of children and young people, we identified a few things that came out really clearly. And by the way, all these little illustrations are what children themselves scribbled down when we invited them to reflect on things. And so we just pulled some of these out. So what we think, and these were clear messages. Good research must happen, but the word good is very important here. It's not just any research. The research has to be good. That needs to be appropriate, prioritised, properly constructed. There are many ways in which one can think about it as good, or one can also see research that is bad. But good research must happen. Young children can and do express their wishes about how they want to live their lives. And children of very young age can express their wishes. That doesn't mean to say that we simply follow them in all cases, but it's important to have the opportunity to hear those things and to take them into account to the extent that they can be. Again, something I'll come back to. And this was something that, again, I mean, maybe we've heard this before, but it was such a strong message, is that we should think about research being with children rather than on children. This isn't just something that we hear in relation to children. It happens in the relationship between high-income countries and low-income countries, where you've got an imbalance of power, an imbalance of in all kind of elements of the relationship, where research funded from the US, the UK or Europe is being carried out in low and middle income countries, and too often, certainly in the past, this is about being research on a community or in a community rather than constructing a participatory approach or a partnership approach. So we hear this a lot. Research should be with children and not on children. But children, in a way, one might come to the conclusion that we just arrive at the point where research with children is therefore no different to research with or amongst any other groups. But there are different features. There are things about children that are special. Just picking out a couple of significant things for these purposes. One is about the way that children develop. So there are all sorts of stages, and we can't cut them off with particular age groups, but developing from the newborn state through to adulthood. There's obviously a progression of development that can happen at different rates in different ways for different people. And the other element is the role of parents. Or parents, or those people who are in a position of responsibility or authority for taking decisions with or about children. And so these are a role where the parents have some responsibility. They are involved in a family situation, and we need to think about how that might be conducted, which won't always be the same. But it's true of all of us as well. I mean, I don't take many decisions for myself without talking to some other people about it being a decision that is situated within a kind of set of dynamics, whether it's family, friends or colleagues or other things. So the role of the parent is a particularly interesting one in this case. But nor is it a simple one. If we think about the kind of things that parents might think about if their child might be invited to participate in research, or if their child's condition is such that only a research option is available, or whatever the circumstance might be, is first how parents, one might say should, but one would hope that do respect their children as individuals. Children may or may not have capacity, but they still are individuals worthy of that regard. They're not the property of the parents, but they are people who will warrant that consideration. The next is that their capacity is always developing. And that's not just something that parents would note or observe. The parent also has a responsibility to support that development. So part of what the parent might do is to think about ways in which this experience of involvement in research might be something that helps the child to in that kind of development. And interestingly, that's in the concern that they have for their child and their welfare. it is not necessarily something that is immediate, it's something that can reflect on the future as well. So the child's welfare is not simply about a physical response to the particular situation, but a broader sense of what is the well-being, the interests and future interests of the child. And welfare is quite possibly quite a complex idea. The immediate physical and emotional welfare of the child is clearly an immediate concern, but the extent to which the child may have opportunities to develop is also part of their welfare. And in doing that, one might also think of the extent to which the child will be building their own sense of their possible contribution within a social group. So that if we think about participating in research as an altruistic act, as well as potentially giving us some benefit, then we can see that this is part of their well-being, their development and their own welfare. And we actually heard this from children a lot, which was a clear recognition, even from very young children, that what they were doing was not simply directed at themselves, but they would also assist in providing better healthcare and better treatment for other children in the future. I've got a few of these. This is a short version of the report that we published that was a sort of accessible version. And we've got some nice quotes on here from children. Why they might participate in research. Well, I want to help children, but they could make the tablets smaller. It was this was kind of picked up quite regularly. Helping other people. I would like to take part in this to help other people. So it's part of their own interest and their own development that parents would take into account as recognising the child's welfare and development. So just moving to where we kind of arrived at in what we thought were important things to then communicate and lead to some recommendations. One was about shared decision making for research participation. So if we recognise that as a parent we're not simply a decision maker but have regard for the welfare and the involvement of the child, then actively participating and sharing decision making can be important. And we identified, rather than saying we've got different ages at which you should treat children differently, there are rather three kind of situations that we might think about. One is where the child clearly is not in a position to participate, to contribute to that discussion, to say what they think. It may be simply because they are far too young. They may be newborns. It may be that they are ordinarily perfectly capable, but are simply unconscious, whether it's through trauma or illness or other things. So we may think about those where there is simply no realistic way of enabling children to take part. There will be a further case which will be a kind of on a continuum of where children may be in a position to express their wishes, and certainly from quite a young age, capable of understanding what's going on, even if they're not going to be the decision maker. But we would expect the parent to take the decisions about whether they might participate, but encourage the discussion and the involvement and listening to their children. And then there will be the third set of circumstances where effectively the child, in legal terms let's say, might not be considered an adult in law, but is effectively capable of making their own decisions. And in those cases we might say then they should. But we also recognise that discussion and involvement with parents may nevertheless be an important aspect of arriving at that kind of decision making. So we just thought, rather than looking at the newborn, the infant, the teenager, the adult, we needed to really think about situations rather than drawing clean lines. And the now, if these are going where I think they should be, yes. So I will simply read this out because I think this is, in a way, quite critical. So the recommendations that we made, and this is basically pitched at those people who are constructing policy, whether it's about funding, conducting research, or working at ground level, as it were, whenever possible, decisions about research should be shared decisions by children and their parents. Where children have sufficient maturity and understanding, but are minors, consent should be sought from both parents and children. And then we come to the third situation. It's, again, one may say we kind of understand this. We've got the Gillick ruling, which is about age and understanding of children to make decisions. There may be circumstances where, for example, research ethics committees may be asked to agree that despite the children being below an age of majority, that they may wish to say that parental consent is not needed, and this may be in cases that are particularly sensitive, whether it's about sexual activity, drug use, or things that are likely to be where the parents may be sensitive because the parent may be implicated in some of the issues, but also where you simply won't get honest answers from children in important areas of research. That's a challenge for research ethics committees. But the basic point is, children should be involved as possible in decisions about clinical research to the extent that they are able and want to. But we really wanted to think about this more broadly than simply whether this child should participate in this research in this particular circumstance, because some of the questions around research go much ethical considerations around research are much broader than that. This is one key one. What research actually gets done anyway? It may be driven by health need, health burden, the potential for profit from drug companies. We may look at the severity of a particular type of disease or how prevalent it is. Again, which part of the world? There are certainly higher disease burden in low and middle income countries, but that's not necessarily where the focus becomes. And who makes those decisions? How do those decisions get driven? Is it about particular research interests or what the funders are interested in? And we can see that there are different ways of looking at this. If we look at disease burden, about prevalence, then we may find that very rare diseases simply get neglected. That certainly happens. I mean, it's a kind of whole area of interest about rare diseases, or orphan diseases, as they're often known, simply because they don't get attention. They can be particularly severe, albeit for a relatively small number of people. If you do identify a condition that warrants attention, whether to focus on prevention, treatment or care, or indeed cure, treatment or cure, because they're not necessarily the same thing either. If we think about diabetes, there's a very, very important question about the extent to which we prioritise prevention as opposed to treatment, especially at the moment where we can see some very clear reasons why it's risen, but how we can prevent it could be, it may be the more important area. And whether there are constraints on what research might get done, simply because the people funding it have got particular interests. Charities must direct their money to the areas that are covered by their articles of establishment. Commercial companies may be simply looking for where there may be a profit. And the kind of people who are involved in those decisions are various, with various types of interests, whether they are government health departments who are simply looking at an overall state of health within the nation, or that might be driven by a concern for what will produce a more economically productive population. European agencies tend to have a more considered approach where they will look at areas of particular need. Public funding bodies, again, may have strategic ideas, and commercial companies by profit. This is just to illustrate the different interests that might drive the prioritisation of research. The question becomes, who decides that? And this is a quote from a World Health Organization document, don't have the reference for it just now. But WHO, in thinking about this, said this: given the complexities of these judgments on priorities, made more complex still by the myriad of potential funding sources, we conclude that our primary ethical concern with respect to prioritisation should relate to the process by which such decisions are reached. So in other words, we can't simply say this choice would be more ethical because we have got a range of different factors that will be in play, a range of different interests, changing sets of circumstances, different areas of the world where priorities might be different. So the question is, what is the process by which we arrive at those type of prioritisation decisions? And who is involved in that process? Who gets to have a voice in considering that? And children and young people and their parents are important stakeholders when we think about prioritising research for children. They usually don't have much of a voice in those things. But there are ways of doing it. So if we think about engagement in those priority setting processes, the James Lind Alliance is a kind of charity-based organisation that brings together people from different sectors, from government agencies, from funding bodies, but also from charities, patient support groups, children and young people, and their parents themselves. And they bring them together so that they can kind of scan the whole arena and then try and direct through authoritative recommendations, as it were, the areas of priority for research. And this has happened in a number of areas. For example, preterm babies, they have a major report from a few years ago, and they're working on the same approach in other areas, for example, in teenage cancer care. So we can think about the ethics of involving individual children in research, about how it relates to different types of communities, about how research is prioritised. And then there are a couple of other areas where we found it interesting and important to pursue. One of these, again, something that kept coming back time and again, was this idea of vulnerability, which was that the reason why we're concerned about children, the reason we must protect them, is because they are vulnerable. And we're really quite troubled by this, because there is a general presumption of vulnerability in children, that they are vulnerable, and that if we therefore are in doubt, then we should simply not proceed with research, because that's exploiting a vulnerability and imposing a risk. But it's not a neutral thing to simply say, let's not do the research, because we simply then leave ourselves in a state where children are poorly served by treatment and by attention for research. And so the question is, why, in what ways can children be vulnerable? For me, the answer is, in a way, the same way in which the rest of us can be vulnerable. We all can be vulnerable depending on the situation in which we find ourselves. If we don't have much information, if we don't have much control, if we're not much involved in what's happening, then we will be vulnerable. So we don't use the term in isolation. It almost has to be in relation to something. And then the question then is, if that vulnerability relates to something, is there not something that we can do about that? So if I were in that situation, to have better information, to have good understanding about it, to be involved in it, is a way of reducing vulnerability. And that's something that we can apply no less to children than we can to anybody else. So I think our appeal is not to think of vulnerability as an intrinsic state that children suffer, but something that, if we recognise it, we then think about it, we pause. So, is this a situation in which people might be vulnerable? If that's the case, what are the challenges that this particular proposal, whether it's a research intervention or anything else, what are the particular challenges that this raises? Can we do something about that, and who can help? And I think that this question about information, engagement, involvement, understanding, discussion, and to some extent this partnership question between researchers and families, parents and children, is a way of helping diminish the vulnerability, or at least recognise it and respond to it. So we then think, well, who are the people who are engaged in this set of processes, and how do we try to construct that? One thing is about partnership, and once again, this is something that we keep coming back to, which is breaking down this relationship, and you can think about it in terms of power relationships between those with the money, those on the other end of it, those in rich countries, those in low-income countries, and trying to break that down by constructing partnerships whereby you hear the voices of those people who are who've got less of a voice at the moment, and you can do that with children, with young people, with families, in those areas of prioritising and designing and reviewing research. There was just as a kind of almost trivial anecdote, but I found this one kind of struck me quite forcefully. Thinking about the design of research, we had an interesting encounter where there was a particular kind of research project, and I wasn't doing it, but the child was asked, who did have a particular illness, and there was a research project, and they were asked, well, what do you want to get from this? And the child said, well, I just want to be able to go to school every day, just like every other normal, healthy child. And so the lead clinical researcher was asked, well, what do you want to get from this? And they said, well, we just want to, cure the child. But there was a kind of interesting element of the design of the research protocol, which was that the child has to leave school every Tuesday and Thursday morning in order to go to the clinic. So the very thing that the child wanted to get was the thing that they were being frustrated in. So that's just a kind of small example of how actually listening to, helping construct things in a way that are responsive to those interests can actually change the way that you do it. In a way to engage people more constructively, but also more profitably in terms of getting outcomes. The responsibility, of course, remains with certain professional groups in terms of how they conduct things. One of those interesting areas is, I haven't talked much about this, curiously, and to some extent this is often the central focus when we ask about ethics of medical research, is the role of the Research Ethics Committee. And of course every research proposal has to go through and be approved by a Research Ethics Committee, which will typically consist of some research experts, also people with a legal background, and some lay people based around university or health institutions. And so the role of the Research Ethics Committee is an important one, and they typically will focus on some basic elements. Is the research of clinical value? Is the consent process appropriate? Is the level of risk one that is low enough to warrant the research? And this is an important area where the role of the Research Ethics Committee is not simply to protect, but also in some ways to facilitate good research. As we go back then right to the beginning, where what we heard from children is that good research must be done. So the role of the Research Ethics Committee must also be facilitative. And this question about the judgment that is then made about whether there is some risk, how it's being prioritised, how the research has been constructed, how children and young people have been involved in it up to this point, and what is being proposed, whether it's about there being any inducement or there being any other kind of offer. Is it fair? There isn't a straightforward answer that we can give to that kind of question in the abstract, but we simply invite research ethics committees to consider whether the offer is fair. And we might think about that particularly in the context of, for example, the centre in Kalifi, where the research comes with sometimes a package of healthcare, but also the possibility of some future benefit, if not for those particular children. An area that we found particularly troubling, in a way, was that too often research ethics committees that are considering research proposals that will involve children do not have paediatric expertise. They don't have access to paediatric expertise. And that's kind of unfortunate because, for obvious reasons, it's very difficult for the rest of us who are looking at these things to make some kind of evaluation of, what is what kind of priority we should give to this, what is the potential outcome, and whether this research is likely to be of a particular kind of benefit. And so we've tried to appeal to those working across the health sector, the Royal College of Paediatric and Child Health and others, to try and ensure that paediatricians are given the opportunity, given the time, which is a real challenge, to make themselves available either as members of or as advisors to those research ethics committees that consider research proposals involving children. So, ethical scrutiny. One last area that is a really difficult one is the role of researchers themselves. Researchers will clearly benefit from having what is sometimes huge volumes of guidance, of rules, of ways of approaching research, and they obviously will need to have regard to the guidance from funding agencies, those which relate to the research ethics review process, and clinical guidance for activity in the clinic. But we kind of came to understand that simply following rules doesn't really get to the point of the kind of values that are applied, those things, those personal values that are brought to bear in this arena, this environment of engagement with children in research. And however many rules you use, there are certain values that you want to bring to this. And we just thought these were important ones. Being trustworthy. The little quote here says you'd want them to be friendly, to be trustworthy. You want to build up a relationship with them. So to behave, to exhibit that characteristic of trustworthiness. To be open. So this is just in support of this idea that engaging people is the way to not just reduce their vulnerability, but to engage them and to give them a voice and some participation that is meaningful. And to be courageous. It's difficult to commit to involving children in research for all the reasons that we have kind of this protective instinct. But it's important that children do have the best healthcare and treatments that are available to. And often it does take courage on the part of researchers to actually engage and to pursue those things when too often people will be saying, but this is too risky, but we can't put children to that kind of risk. So it's something that we want to encourage researchers to think about. So that's a kind of broad sweep. We try to land it in a number of ways with recommendations to funders about how to engage people with different voices in priority setting, to the research ethics community and how to encourage a broader approach to thinking about research ethics and involvement of relevant expertise, to policymakers to make sure that guidance supports it in the right kind of ways, and indeed to researchers themselves, those putting together research proposals. So for example, we've just set out not a checklist, but a list of areas that they might address their minds to when thinking about constructing research, about whether they've involved children and young people and their parents. Is it a fair offer? Have you communicated with the people in the communities likely to be involved? Will you be returning results to people? Those people who've been involved, one of the things that children kept saying was, that's all very well, but will they tell us afterwards what happened? Not just about their own benefit, and we hear this in many, many people who are involved in research. Curiously, nobody thinks to go back and say, thank you, that really helped a lot, because now we've found this thing. And actually to get that feedback is actually really constructive. So we've pushed this out in all kinds of ways. We have a 200-page report that 3 or 4 of us have read. We've got the short version of the report, which I've got some copies here. We've got a one-page version, which is for MPs, because I'm told that MPs are very good at reading, but they're not very good at turning pages. And we also, however, we really wanted to get this to people who might not otherwise be reached. And so we've actually got, this is the magazine version that we produced, a one-page summary which also includes this kind of set of prompts for researchers. We've worked with some people in University of Oxford who were connected to the centre in Kalifi, who've helped us to produce a kind of online course that's available for all kinds of health professionals, in whatever area they're involved in. And an animation, which is essentially going through with a child, with her family, the kind of things that she and they will be challenged with in thinking about it, and how they might relate to the researcher and try and make their decisions. There wasn't enough room on my memory stick to load the whole video, but you can pick all of this up online here, and all of these resources are available. And I would like to think they're interesting to read, as well as being helpful to those people who might be involved in research from all of those perspectives, from children through families and researchers, etc. The kind of, sorry, 10 to 7. We could kind of talk lots more about it. It's been really, really interesting work from our point of view, and I hope that other people have found it useful and interesting too. Thank you.
In our last 10 minutes before the caretakers come and boot us out, does anyone have any questions for you?
That's really interesting. Thank you very much, Andy. My question is about whether there has been very much research on the kind of longer term impact on children who've participated in research projects. Children who've either had a direct benefit, and possibly even more children for whom there has been no direct therapeutic benefit.
I suspect, I can't say with certainty, but I suspect the answer is no. And you have to kind of look at different sectors in a way. I mean, those people who actually conduct the research, they kind of come to the end of the story, they publish their results.
Well, that's what I was wondering. Yeah.
And that's kind of the end of it. Now, I think that there are people who are working around medical sociology who might have an interest in those areas. And there are certainly people who do quite long-term, longitudinal studies with children in different aspects of their life, whether it's about psychological development and other things. But I'm not aware that there's very much around that particular question that you're asking, which is, a really interesting one about, how do they feel 3, 5 or 10 years down the line.
I suppose the question is, where does the ethical consideration begin and end? Is it simply, putting in place a kind of an ethical structure with which you feel happy about a child or children participating, but what about the kind of longer term effects or impact?
Good question. All I can say is I'm not aware of it. It may be that I'm just not aware of something that is there, but I suspect not much. But I think it does touch on this notion that, and it happens in most medical research, and we look at things like the biobank where people are contributing biological material, and they have committed to, reporting back to all of their contributors, what gets done later. That is so rare, and I think this interest that children have expressed in saying, well, I want to know what came of it, is just not really addressed.
Any other questions?
Is there sort of, I'm sure it's not a universally accepted, but how young are we talking? Because as I listen to you talk, I think to myself, are we talking about a child who doesn't know how to read yet, but we're going to take their advice or suggestion on medical research? It's kind of, it just seems bizarre. I mean, I guess, as you say, the research has to get done if you want to get the results to provide better care in the future. But it's just, is there a number where they say this is, you know, we're getting into waters that are a little murky, whether or not this child has any comprehension at all of what we're explaining, as they say, because children are often people pleasers, and if mommy and daddy are nodding, then the child may just nod along with them, and great, they nodded, let's go.
Yeah, and absolutely. Or you know, the child may be shaking their head violently, but you still got to stick the needle in them. I mean, you don't have to. It's research,
Right?
But
I understand.
but I think that's. I think, you know, part of what I'm trying to get to is that you consider for each child what is appropriate and what is meaningful. So a child who may only be 3 years old, certainly not in a position to read, you know, 6 pages of patient information.
Right.
You know, most of us don't understand that stuff. But nevertheless, there are ways of talking to them, hearing them, and then putting that in its right context. Just you know, giving it a perspective that is appropriate to that child in that place. And it may be that you kind of override it if this is a research where there is no alternative treatment available, there is some prospect of benefit. It's a delicate situation.
Right. That's what I mean. It's not you understand what the goal is.
Yeah.
But it's a very complex.
Sure, and but on the other hand, you know, if this is a procedure for which there is no prospect of benefit for this child, this may be a healthy child, you know, completely healthy child, participating in research into a vaccine, let's imagine, and there's not necessarily any real prospect of benefit for that child. And then if they're freaked out by a needle, you may say no. You know, there isn't sufficient, you know, overriding benefit here for that. But I don't think there's an answer. But the point is merely, don't simply ignore them simply because they they're under 5. It's, you know, they've got nothing to say. So it's drawing lines between things is easier to do, but actually ignores the point that, you know, there is something to listen to, and it's going to have some kind of standing within a family environment. You know, the parents may be able to read the signals in a way that the doctor can't. So I don't know. I don't think there's an easy answer to it.
Yeah,
But that's a good point. Yeah. Sorry.
Thanks very much. That was very interesting to a subject that's completely new to me. I couldn't get my head around therapeutic misconception.
Yeah. You're probably better at this than I am.
Is it actually challenging our entire faith in medicine? I mean, we go to a doctor because we want to be cured.
Yeah.
Is therapeutic misconception saying that we can't be sure of that? Adults make mistakes, experts make mistakes. Is that what it is?
No, I think you have to see the therapeutic misconception simply in the context of research, not about regular treatment that you might expect from your doctor. It's really only in a research context whereby, let's imagine a clinical trial of a new drug. So this drug hasn't yet been licensed, it's not on the market, it's not yet prescribed for a condition. Let's think about asthma, I don't know. But it's going through that phase of development and research where, having been tested with animals or in the laboratory, we're now ready to see whether it's effective in humans. And we have this notion of equilibrium. And the equilibrium is, in principle, the idea that the reason we have to test it at this stage before we license it is because we genuinely don't know whether it's going to have the therapeutic effect that we think, that is better or worse than what existing options are available. This is the idea of equilibrium. Now, that's why we have to have carefully constructed, controlled, ethically reviewed regulation around medical research, so that you can, test that. So if in principle we have this equilibrium between the potential for benefit and the potential that it's going to do nothing, or it might be harmful, the patient, we have to make sure they understand that they're not coming in here for a treatment. What they're coming in here for is to participate in research that's got some prospect of benefit, but some prospect of no benefit, or even some potential harm as well. And the therapeutic misconception, which is very easy for us all to fall into, is to be involved in that research as the patient, as it were, believing that this is my treatment, as it were, that the benefit is what I'm going to get. And it's a kind of difficult thing to, it is a difficult thing to get your head around, because why else are you doing it?
Yeah.
I mean, if you are a patient suffering of a disease. But I think the important thing from the researcher's point of view is to say that if you think you're coming in here and you're just going to get the best treatment there is because it's new, then you've misunderstood what the research principle is about.
Right. And this will be beyond the level of a child.
Now, that's a really interesting question. One might say so, and if you think of children as they develop, you say, well, what is the point at which they might comprehend that? And some of us, frankly, as adults, will never comprehend it. But some kids of 6 may well do. And we certainly saw this in some of our responses. I know this won't help me, but I want it to help for somebody in the future. Even though what I'm receiving is a medical intervention, I get it, that this might not help me.
But what about, you mentioned research that has no therapeutic benefit, which I mishear that. You said there is some research where there is no aim of a therapeutic, but how do you sell that?
Well, so in children, I don't know to what extent one might expect to see this in children. So there are difficult areas where you think about public health interventions, vaccinations. Now, it's a difficult one in introducing a new vaccination program. We might think it's for malaria, or it may be for something like flu. And the child themselves does not have malaria or flu.
All right, but you're not saying that it doesn't have a therapeutic benefit for somebody at some point.
It's got that's right, it may have a protective benefit for some other person in the future, but you're not expecting there to be a therapeutic benefit for that person.
So it's not purely experimental, just for the sake of whatever you can find out.
There are, there are some interesting, some really interesting stuff. So if you've got a completely novel experimental intervention, the early stages of clinical trials are done on healthy volunteers.
Right.
And they are intended not to test the therapeutic benefit, but the toxicity of the drug. There was a famous case at Northwick Park where half a dozen young men, healthy volunteers, took a novel drug which was not intended to cure them, but just to test whether it was going to be toxic. They were given £3,000 each to, if you like, compensate them for their time and trouble, and they were seriously ill. Now, that was a risk that they took. They understood that, and they had to understand the situation that they were in. That's not the situation that we're talking about in this particular type of context. I don't think you would do that with children. Curiously, after that, what you might not expect is that this is a completely different question. I found this really interesting. After that case came to light, it was, big story. So these guys had been paid £3,000, but were seriously ill. After that, the number of people who volunteered for clinical trials went up.
It's the £3,000 that did it.
They didn't all see it through, but the people who volunteered, there was an increase. So that's the kind of some of the delicate questions that research ethics has to manage, is what is a fair offer?
I'm afraid we are likely to get caretakers banging on the door.
One more.
I was just wondering what happens if the child wants to take part in some research, particularly if it's going to affect them, but the parent doesn't want to. Who has jurisdiction then?
Ultimately, if the child is below an age of maturity, then the parent will
Can I rule?
probably be able to overrule them. I think it does become difficult if you've got a child who is 16, 17, who is perfectly capable of making their own decision. It can become problematic. I think that one would have to look at particular sets of circumstances, and I think that the conversations that take place between the family, the researcher and the child have to be, situation specific.
Thank you.
Thank you. That was excellent.